Evening everybody, and welcome to Getting to the Heart of Fertility, New Life IVF's monthly webinar series. And tonight we're talking about unexplained infertility, and we're going to explain what that is, which is a bit of a paradox, but we've got two really great speakers here for you tonight. We've got Associate Professor Martin Healy and Dr. Amber Kennedy, who will take you through this very important topic. As always, we will start with a presentation and we will end with your questions. The questions are the best part of the night, so please send us through plenty of them. The way to send through the questions is to use the chat feature within Vimeo, or alternatively, if you have difficulties with that, please email through your questions to newlife@newlifeivf.com.au. So we're about to get started. I'm going to invite Professor Martin Healy to take the floor. I beg your pardon, it's going to be Dr. Amber Kennedy. We're going to have to wait for Martin. Amber will warm us up and we'll get started in just a few minutes.
Hello everyone. Thanks for tuning in tonight. I sincerely hope that you're all staying sane out there. Tonight we're going to be talking about unexplained infertility, and hopefully a little bit of the mystery behind that will be explained by the end of this evening. So in talking about unexplained infertility, first I'm going to talk about what is fertility. And then I'll talk about what exactly do we mean by unexplained infertility. And we'll talk about, can you get pregnant naturally when you've been given this diagnosis? And what are the treatment options available? Now first, this is a very detailed and overwhelming image, and deliberately so because what it illustrates is all the components, all the aspects of fertility that need to go just right in order for you to conceive naturally. So in order to conceive naturally, you need to ovulate or release an egg that's good quality and normal genetically. That egg needs to meet sperm that is fertile sperm that is in the genital tract because you have had appropriately timed intercourse. You need to have functional tubes and a receptive endometrium in order for the embryo to implant. And on a cellular level, the egg and the sperm, they need to have all their components working effectively and all their cellular mechanisms intact, so that fertilization can occur, the zygote can begin to divide and turn into an embryo and progress to a blastocyst, so that blastocyst can then implant, and so on. So it's not surprising why we see, at best, in young fertile women, per month pregnancy rates of only about 25%. And that rate does start to decline at about age 30, such that when you get to in your early 40s, at age 43 for example, the per month pregnancy rate is only about 2%. All right, so now to some strict definitions. So infertility is defined as failure to achieve a pregnancy after 12 cycles of regular intercourse without the use of contraception. And so unexplained infertility is infertility where no attributable cause has been found after a standard workup. And what do we mean by a standard workup? So for the male partner, simply that's usually just a semen analysis, where we look at a sample of sperm under the microscope and we measure parameters such as volume of semen, concentration of sperm, total sperm number, motility, which is the ability of the sperm to swim forwards, and morphology, which is the shape, what the sperm look like under the microscope. And we can calculate something called the total motile sperm count, which is the total number of swimming sperm in the sample, and that's probably the most important and useful measure. Usually we say about 20 million is normal, but that by no means is a binary cutoff, where above 20 million swimming sperm means that the male partner is fertile and under 20 million they're infertile. But we do see reduced fertility as that number reduces. And so for the female partner, there's a few more tests to undergo. We do baseline hormones, usually done at the start of your period. And also via a blood test that's done after ovulation, usually about 7 days after expected ovulation, we confirm that in fact you are ovulating regularly. we usually need to perform a tubal patency test and a pelvic ultrasound. Now down the bottom here you can see a tubal patency study, which can be done a few different ways, but in this diagram it's being done via an X-ray. So a dye is injected through the cervix and we watch that dye spill out through the tubes, and the diagram on the left is a normal study where the dye has flowed easily down each tube, and so this is a normal tubal patency test. On the right hand side, this patient's tube, this is the left hand tube, this tube is not allowing the dye to pass, and so the assumption is that tube is actually blocked. So about 30% of couples will have normal sperm, confirmed ovulation, at least one working fallopian tube, appropriately timed intercourse, and normal pelvic anatomy, so no endometriosis, no significant fibroids or adenomyosis. So this is exactly what unexplained infertility is. But perhaps a better term is unexplained subfertility. And I'll talk about what I mean by that in a bit more detail. So the most common cause of decreased fertility in normal women is age, and we see decreasing fertility as age increases, as I've said before, and this is because of falling egg reserve and reduced egg quality. So the numbers that I showed in the very first graph can be put another way and mathematically added up to your probability or cumulative chance of conceiving after 12 months. Remembering that 12 months is the definition of infertility. So at 25, where the risk of conceiving in each given month is 25%, the cumulative probability of achieving a successful pregnancy after 12 months in a 25-year-old is greater than 95%. Only a very small percentage will not be pregnant. But contrast that to at age 35, where after 12 months of trying to conceive, only about 75% of normal women will have fallen pregnant naturally. And so it's this 25% that meet the definition of infertility and unexplained infertility or subfertility. Importantly, it is possible to fall pregnant in the subsequent 12 months and even in the 12 months after that. So for the male partner, we do, like I said before, see decreasing fertility with reduced semen analysis parameters as well. So what does this mean for you specifically? Well, I find a very useful website to find out what your personal chances are based on your circumstances is the Your Fertility website, which can be found at www.yourfertility.org.au. And when you get there, you can navigate through the menu to a very useful tool specifically for unexplained subfertility. The tool will ask you to answer these questions, and I've done this here for you, just a hypothetical couple, where we say, what is the female's age? And I've answered 38 years old. How long have you been trying to conceive? Approximately 13 months. What is the percentage of sperm that move normally, i.e. what's the motility of the semen analysis? And I've said 45%, which is a normal value. And have you had a previous pregnancy with your current partner or a past partner or sperm donor? And I've answered no, and then you can click submit. And it will give you this output. So in this specific example, there will be a 22% chance of falling pregnant naturally if you try for another 12 months, 31% chance of conceiving with 6 cycles of IUI, and a 46% chance of conceiving with 2 cycles of IVF. And so it gives an overall recommendation that in these circumstances you might want to discuss this with a fertility specialist. And just to give you another example, I've changed the maternal age to 28, and this gives you this kind of an output with a 38% chance of falling pregnant naturally in 12 months, and nearly 70% chance with 2 cycles of IVF. And the overall recommendation is somewhere in the middle for that. So you can put your own details into this website and find out what your chances are. So once you have that information, what to do next is different for everybody, taking into account your personal set of circumstances. But now I'm going to hand over to Associate Professor Martin Healy, who's another one of the New Life IVF fertility specialists, and he's going to tell you about the treatment options and how to optimise your chances of achieving a successful pregnancy.
Hi, I'm Martin Healy, and thank you, Amber, for your very kind introduction and for sort of spelling out really nicely what unexplained infertility is and how we get to making that diagnosis. When it comes to treatment, I think you need to start with the really simple, and I'm very simple-minded, so that works very well for me. So the first thing that I always want to remind patients about is working on your lifestyle, that this does not magically make everyone pregnant, but it can help. And some people just with simple lifestyle factors will go from not being pregnant to getting pregnant. And even if you don't get pregnant, when it comes to needing assistance in various forms that infertility specialists provide you, the better the quality of your lifestyle, the better the chance we've got of helping. And so really simple things that everyone finds boring. If you're a smoker, please stop smoking. And this goes for both the guys and the girls, that the effect of smoking is negative both sides of the fence. Alcohol, it's helpful to reduce alcohol intake, and so we would generally recommend that most people would be having 1 drink a day. Less is probably better, but it's always a balance between what you can manage and what is going to drive you crazy. As a caffeine addict, the next two really hurt me more, and that is to try and limit coffee and tea to 1 a day as well. Exercise in moderate amounts, I think, is been shown to be helpful, and so trying to be sure that you're having regular exercise. The other end of that spectrum is becoming obsessed with exercise, and there is some evidence to suggest that excessive exercise goes the other way and it starts to have a negative impact on your overall fertility as well. Specifically for women, but there is almost certainly some aspects of this that are true for guys as well, is if you're overweight, bringing your weight down into the normal range can have benefit as well. So simple stuff. Hard to do for most of us is to work on your lifestyle and just try and get it as good as possible. And there is not a huge gain, but there is some gain here. So, sorry, I've just jumped a slide. So the next thing to say is that when we then go to say, well, where to from here, the simplest thing and an option that a lot of people will choose is to say, well, I just want to know what's going on. You've told me that there's nothing has been found in the tests. Can I just keep on trying naturally? And the answer is, for subfertility where we've found no cause, absolutely yes, that is a reasonable treatment option. You need to look at your situation and ask yourself, is this the only treatment you will do for the future, or would you look at other treatments? Because one of the issues is your age. And so as you get older, the longer you try naturally, the lower the quality of your eggs over time. And then if you do end up needing to use other forms of treatment such as IVF or intrauterine insemination or one of those, the quality of your eggs becomes a factor. And so trying naturally is very reasonable. Trying naturally for long periods of time is very reasonable. But the older you are, the more you need to balance. Do I keep on trying naturally where I am seeing opportunity for other treatments to be more effective become less effective over time? And so that means you need to be realistic about what are your chances of success with trying naturally, and is it worth it? Somewhere in there, it's worth saying that with trying naturally, use of urine ovulation kits can be helpful. there are a few trials showing a little bit of benefit there, that it increases the pregnancy rates a little bit because it allows people to time their intercourse a little bit more accurately. And so that's something to consider. This is a adaptation from a study that came out last year looking at several trials that have been done with trying naturally in women with unexplained infertility or subfertility. So these are women who've been trying for at least 12 months who are then followed with attempting natural conception for a further 12 months. And the take-home message from these is the right-hand side of the graph, where women in their mid-30s are getting about a 20 to 25% ongoing pregnancy rate from another 12 months of trying. Women in their early 40s and mid-40s are down to a 10 to 12% chance of falling pregnant in the next 12 months of trying. So what that's saying is, if you're younger, you've probably got a 2% per month pregnancy rate. If you're into your 40s, you're looking at probably a 1% per month pregnancy rate with trying naturally. And the longer you try, the older you get. And once you're into your 40s, you're watching the quality of your eggs go downhill. And so this is where how long you try becomes relevant. What else can you do? So there are a number of other treatments that have been around for a while. The first is intrauterine insemination, and this is where, or artificial insemination is the other term, this is where the partner provides a sperm sample. In the lab they concentrate the sperm, and then we use a very fine catheter to inject it into the uterus. Specifically, we want to do it at the right time, and so we do monitoring to work out when the woman is about to ovulate, and we look at injecting the sperm on the day of ovulation or possibly the day before. This is safe to do so long as there are a limited number of eggs being released with ovulation. However, if there are a lot of eggs being released with ovulation, then we can run into trouble with multiple pregnancies. Specifically, doing intrauterine insemination by itself without stimulating the ovaries, the success rate is no better than just doing natural conception in women with unexplained infertility. What we generally do is do intrauterine insemination in combination with ovulation induction, where we're stimulating the ovaries to produce not one egg, but hopefully 2 or 3. We don't want lots, we want a little bit more than one egg to give us a bit of an extra chance. And the big studies that have been done show that with this, we're looking at about a 3 times the pregnancy rate of trying naturally using intrauterine insemination plus ovulation induction. There are a couple of different drugs we commonly use called clomiphene and letrozole. People have also in the past used FSH injections with this. This has tended to be frowned on nowadays because of a much higher multiple pregnancy rate in using this kind of medication. It doesn't give an overall better pregnancy rate, but those that do get pregnant have got a much higher rate of twins and triplets, and so we would prefer to use either clomiphene or letrozole as the drugs of choice in this situation. The final treatment that we use in women with unexplained infertility is in vitro fertilisation, or IVF. And this is a process that a lot of you will have already done homework on and understand. We stimulate the woman with a drug called FSH so that she produces multiple eggs. We steal the eggs from her. In the laboratory, we fertilise the eggs with sperm that her partner has provided, grow the embryos in the laboratory for 5 days, and then transfer an embryo back into the uterus. If there are excess embryos that have been produced, then we'll freeze them and they can be used later if needed. When IVF is compared to doing intrauterine insemination with ovulation induction, we get approximately double the pregnancy rate with IVF that we would with IUI. in studies that have looked at sort of an efficiency aspect of it, generally with IVF there's a shorter time to pregnancy and overall a cheaper cost, although it seems to cost more at the time. People ask about the ICSI process, which is where we inject the egg with an individual sperm as the fertilisation approach, compared to standard IVF where we take a single droplet of sperm and put the egg in the single droplet and let the fastest sperm win. The pregnancy rates are no different for the two of them in women with, or in couples, with unexplained infertility. Overall, and these are rough numbers to give you a bit of an idea, with trying to get pregnant naturally, you're looking at best numbers about 2% pregnancy per cycle. With stimulated IUI, you're looking at somewhere best numbers 8 to 12% per cycle, and with IVF, you're looking at pregnancy rates 20 to 40% per cycle. And I've given a much wider range with IVF because of the whole issue that different clinics will get different results, and also the age effect becomes very important. This is true of all of these approaches, but probably more so with IVF than the rest. There are some things that have been shown not to be helpful. Doing ovulation induction by itself isn't helpful. So just saying, well, can you give me some clomiphene tablets? I'm already ovulating, but maybe 2 eggs instead of 1 will do better. There's good studies that show this doesn't improve the pregnancy rate. Also, intrauterine insemination without stimulating the ovaries to produce that second or third egg doesn't give a better rate than just getting pregnant naturally. So an overall approach that I think is reasonable, and this is not necessarily going to work for everyone, there is variation on this, but an overall approach that is reasonable is to, number one, get the couple who have got this issue to work on lifestyle factors and see if we can't get them optimised. The second is, if they are younger and they are wanting to just keep on trying naturally, to say, yep, go for it, but suggest using ovulation kits to make sure that they're getting their timing right. However, if a couple want to give themselves a higher chance of getting pregnant and they're younger, or the woman is younger, then I would be saying it's a reasonable thing to try 3 or 4 cycles of IUI with stimulation. And then if they're not pregnant with those, head in the direction of IVF. If a woman's older than 38, then the tendency would be to talk about going straight to IVF sooner, because we're dealing with eggs that are getting older faster and a falling success rate with those aging, with the aging of those eggs.
Okay, thanks, Martin. So I've got a few questions that have been submitted. The first one is about an IVF cycle, which asks, when your standard cycles are 30 to 33 days after starting IVF with donor sperm, the cycles then start to blow out to 36 to 40 days in length with all normal bloods. Does this indicate a bad cycle or early menopause, or perhaps some underlying stresses? So there's a few reasons why an IVF cycle might be longer than a natural cycle. If you think about when you normally ovulate, which is 14 days before your period comes, so in a 30-day cycle, that's about day 16 of your natural cycle. So in an IVF cycle, we start giving the stimulation medications, and we continue to track the follicular development until there's the right number and the right size of follicles. So the first question I would ask about your cycles would be at what time was the egg collection done? Because if the egg collection was delayed because we were waiting for more follicles to develop, or for larger follicles, then it might have been done later than you would have naturally ovulated in your own cycle. And then the second thing is I'm assuming you're talking about a fresh transfer cycle, so a cycle that's progressed to have a transfer, because in these cases you would have usually been prescribed progesterone for luteal phase support, and you continue that progesterone up until the time when you have the HCG, and if the HCG test is negative, then we say you don't need to take the progesterone anymore, and your period will usually not come until after you've stopped the progesterone medication. So without knowing more about your specific cycle details, they would be my two best guesses. And in terms of working out whether it's a bad cycle, in your cycle, we could do day 2 bloods, and that would give us an indication of whether or not before you start a cycle, you could do some bloods to check your baseline hormones. And I don't think that this would be indicating early menopause, and there'd certainly be ways that your fertility specialist could investigate for that. The next question is it safe to have the COVID-19 vaccine during fertility treatment or while trying naturally? And the answer is yes, absolutely. We want you to be vaccinated as soon as you're able to get access to the vaccine, and we understand that is largely the limiting factor is getting an appointment to have your first dose of the vaccine. But it does not affect your fertility, it does not affect you trying to fall pregnant, and it doesn't affect your fertility treatment. And we very much want someone to be who has the opportunity to be vaccinated before pregnancy to be vaccinated before they are pregnant. Okay, the next question is, do you recommend any specific supplements? Well, the first thing to say is all pregnant women should be on, all women who are trying for a pregnancy and pregnant women should be on a prenatal vitamin such as Elevit, which contains folate. And in addition to that, if you've been trying to conceive and you haven't had success, or if you've had IVF cycles that are not where you haven't achieved a pregnancy, or where egg quality has been an issue, sometimes the types of supplements that we talk about are, for example, melatonin or vitamin E or coenzyme Q10. However, these supplements are recommended based on our sort of biological theory that they might be helpful, and there's certainly no concrete evidence that they do work and that they do improve your pregnancy successes. But we don't think that they're harmful, and they may in fact have a benefit. And when we're talking about unexplained subfertility, sometimes those little 1% gains can be useful. All right, I'll hand over to Martin, who is going to answer a few more of your questions. Thank you.
More questions coming. So, first question is a laparoscopy always recommended before starting IVF? And this is where both people in the couple have been tested and all results are normal. And the answer is no. It can be offered, and there are good reasons for offering a laparoscopy, but it's not universally done on all women with infertility. The benefit or the reason for doing a laparoscopy as part of an infertility workup, number one will be it is one way that we can check for whether the tubes are patent, so tubal patency, where we'll inject dye through the tubes and check. The second reason is that it gives us an opportunity to look for a condition called endometriosis, which we see in some women. And so offering a laparoscopy is one approach for checking tubes, but also gaining more information about what's going on in the pelvis. So that is something that is not offered to everyone, it's offered to some people. Second question is, does the prednisolone protocol, otherwise known as the Bondi protocol, improve chances of implantation if no other causes are found? I know this is a common question. So there are many drugs that are used in IVF treatment that sort of come into the zone of what we would call adjuvants, and use of prednisolone is one of them. There's mixed feelings about use of prednisolone. It's a very potent drug and has some negative side effects as well as some potential benefits. In looking through the literature, there is a little bit of evidence to suggest a small increase in pregnancy rates in women who use prednisolone. There's also some small evidence to suggest increased risk of abnormalities in babies in women who use prednisolone. And so there is mixed messages coming from the literature as to whether this is a good idea or not. And so most people look at this and say, if you're going to use it, you need to have a good reason and you need to have good evidence that it is useful because it can cause harm as well. I don't know if that necessarily answers the question directly, but it's trying to say to you, anything you do comes with pros and cons, weigh it up carefully. The next question is, should someone with unexplained infertility ask their fertility specialist for a test for natural killer cells? And here I would say the answer is no, but I'll explain why. Natural killer cells are a type of inflammatory cell or white cell that is found in two places. The first is in the bloodstream and the second is in the endometrium. And they're actually two totally different types of cells. The cells that are found in the endometrium have been associated with a better outcome. So having lots of natural killer cells is associated with a better outcome with regards to getting pregnant. There have been a lot of studies done on this, and there have been a lot of ideas and thoughts people have had. And so people have tried a variety of treatments to try and have an effect on pregnancy outcome where they think they might be having an effect on natural killer cells. So far to date, no one has proven that a treatment that has been used alters natural killer cells and therefore leads to a better pregnancy rate. And so we don't know exactly what the tests that are being done for natural killer cells are showing, and we don't have a treatment that's actually been shown to work that will affect natural killer cells. So at present, there isn't a strong recommendation that people be tested to see what their natural killer cells are with regards to what level they're at, because we don't know what it means and we don't know how to treat it in a way that's been proven to work. The next question, do you recommend PGTA testing? So PGTA or pre-implantation genetic testing for age is testing an embryo to count the chromosomes in the cells in the embryo to see if there's a normal number of chromosomes or not. This is a test that we do when we are concerned about an increased risk of embryos being abnormal, and this is usually done as women get older. There is already a webinar that's specifically focused on this question on our YouTube site, so I'll direct you towards that webinar and say take some time to go through and look at it. The short answer is we don't recommend PGTA testing for everyone, but as women get older, our enthusiasm for suggesting it goes up, and certainly over the age of 40, most of us would be suggesting that women consider doing PGTA testing. Another question is it worthwhile testing sperm for DNA fragmentation? This is tricky. It's like all tests. You've got to ask yourself, what are you going to do with the result? And sperm DNA fragmentation testing is a test that is going to give you a bit of a feel of, is this sperm going to behave normally in the IVF process, or am I going to get results that aren't as good as I expected? Most times we'd be doing this testing in someone where they've already done an IVF cycle or 2 IVF cycles and the fertilisation rate hasn't been as we would have expected, where we've also looked for some other reasons already why that might not occur and have been left sort of scratching our head thinking we're not getting the results we think. An alternative situation we might do DNA fragmentation testing is in someone who's already got known poor quality sperm, for example, say a man who's had radiation treatment for testicular cancer and has still got a few sperm coming out, but we're worried about what the quality is, and so we would do this as an extra test to give us some sort of a feeling for the patient as how likely their sperm might be to give a good result. The difficulty is we can't test an individual sperm and then also use that sperm. So it's a case of we're testing the overall sort of field effect, if you like, in that sperm, in the semen that man is producing, to get a feeling of, is this likely to underperform or perform as we would normally expect. Over to Amber, who will answer some more questions.
All right, so it looks like I've got the last question that's come through for the night, and that is, why are IVF success rates much better than natural cycle success rates? And I usually explain this as it's all about probability and numbers. So in a natural cycle, you inherently just have that one opportunity, that one egg, that one conception, or that one chance at conception. Whereas in an IVF cycle, we're deliberately overstimulating your ovaries so that they produce not just one, but as many eggs as possible. And this number can sort of significantly vary. Sometimes we get a few eggs, sometimes we get very many eggs, and then each one of those eggs has the opportunity then to be fertilised and to progress through to a lovely embryo. Just by the sheer weight of numbers, the chance that you'll have a normal embryo that is able to implant is just much greater as a result of that fact. And I think that is pretty much all we have time for, pretty much all the questions that have come through, and I'm going to hand over to Chris, who's going to sign us off.
Thank you very much, Amber and Martin, for some great talks, and thank you for everyone who's watching tonight for joining us and for the wonderful questions. We do enjoy answering your questions, and we had some really great ones tonight, so thank you so much. Now, the Getting to the Heart of Fertility webinar series continues next month, and our next webinar is scheduled for Tuesday the 5th of October, and we will be talking about the ins and outs of the reproductive tract and ovulation disorders, which promises to be a really important and hopefully entertaining talk. And talking on that topic will be Dr. Hugo Fernandez and Dr. Samir Jatkar. As always, our webinars will be published on our YouTube channel in the coming days. If there's anything you missed out on from tonight's talk or anything that you'd like to hear again, by all means watch the webinar. There's our complete collection of webinars are there as well, past topics, and they are proving very valuable to our patients. The address for the YouTube is youtube.com/c/newlifeivf. I don't know why it's got a C in it, but it does. And otherwise you can search within YouTube itself for New Life IVF. Thank you once again for your attention, and stay safe, stay well, absolutely get vaccinated. It's very safe in fertility treatment and very safe during pregnancy, and hopefully we can see you in person next time. All the best.